So thank you again for your attention. The first point I want to make is with regard to non-responsive or unresponsive choroidal new vessels. The first point is simply that taking care of the AMD patients with anti-VEGF therapy requires chronic treatment. And that's illustrated, I think, well with the Horizon 7 Up study. So we have the patients originally in Marina and Anchor who are getting monthly injections for the first 2 years, and the average of 9 letters of visual improvement. And a subset of these patients ends up being followed less and less and less over time. But what you can see is that they're according to a PR9 treatment schedule, but there's a gradual decline in visual acuity, so that by 5 years, among the cohort that remains, the average improvement is actually a slight loss of vision. That's, of course, discouraging, but it points out the need for ongoing therapy. And lest you feel too discouraged by that, it's important to realize that the control group in Marina and Anchor, who then was assigned to ranibizumab at the termination of the study, although there was clearly some benefit to those patients, they were much worse off than the patients who had been treated aggressively initially. And if we look at a subset of the results here, what we can see is that the patients who got the most injections had the best vision. So, for example, between years 4 and 7, there were an average of 6.8 intravitreal injections given. And the people who had 11 or more injections, which is only a quarter of the patients, were the ones that actually had visual improvement of about 4 letters, compared to the overall cohort, which lost slightly less than 1. So it's a chronic disease. Now, the question is, you've seen this graph before. It shows the number of injections required over a 2-year period in the Harvard study on the x-axis and the percent of patients on the y-axis. Most patients, about half of the patients, don't require monthly injections, but there's a subset of patients who require injections every month. We have to make a distinction, for the purposes of this talk, between people who require ongoing injections and people who are unresponsive. That's not the same thing. Unresponsive means that they don't respond to the injections. A person who needs an injection every month, but whose fluid goes away when you do that, is just someone who needs a lot of injections. That's not an unresponsive patient for the purposes of this discussion. So here's an example of what I would call an unresponsive patient. This person was treated with bevacizumab by Dr. Shlomo Shaul at the University of Louisville. And initially, the patient looks great with marked reduction of fluid, but eventually, when they show up for their next injection, number 4, there's fluid, and by injection number 8, there's a lot of fluid. So this person's no longer responding to the bevacizumab. That's what I mean by unresponsive. The differential diagnosis, what we think about when that happens is, first of all, do we have the right diagnosis? Are we using the wrong medicine for the disease that the patient has? And then another logical thought is inadequate dosing. For reasons of genetics, or perhaps for vitrectomy, or some other reason, some patients may require more frequent or higher doses of medication. And you'll see that's one of the strategies you can explore. And then there's resistance. And resistance is different from the other two. Because if the patient's resistant, increasing the dose or increasing the frequency isn't going to change anything. And resistance is often mislabeled as tachyphylaxis. I'll define tachyphylaxis later on, but that's not what we're usually dealing with. That's a very uncommon event in my opinion. What is the basis of resistance? Well, there are different ways it could evolve. One would be the upregulation of alternate pro-angiogenic pathways. When I showed the data earlier about how everyone's VEGF level was lowered when they received Avastin, well, it turns out only 5% of the patients get hypertension. Only 4% of the patients get thrombosis. This is when they receive Avastin for cancer. But all of those patients have lowered VEGF levels as a result of treatment. So there are alternate pathways that most patients have that bypass the VEGF blockade, but some patients don't have those pathways for some reason, and they get complications. Well, in those patients that have alternate pathways, it's great because it reduces the risk of stroke. But in the case of us treating choroidal neovascularization, alternate pro-angiogenic pathways leads to resistance. And then there could be downregulation of anti-angiogenic pathways, obviously. And then pharmacogenetics. Some people can clear the VEGF blockers faster than other people. Who knows why? Some people may actually develop antibodies to the medications. And there's actually evidence for each of those possibilities in published literature. How common is resistance? Well, it's been looked at in 2 retrospective studies that I'm aware of. In the case of ranibizumab, a study by Ego and Swerson, and they used the term tachyphylaxis to define what I would call resistance, which is the lack of a response to the drug at the time of reactivation in a patient who initially had responded. And they found that the incidence was around 2%, 20 out of about 1,000 patients. So it's not very common in their experience. And then Farugian looked at the development of resistance to bevacizumab in a small series of patients. The way they defined tachyphylaxis, again, I wouldn't use that phrase here, but they did, was the loss of a therapeutic response to bevacizumab a month after administration in an eye that previously had a response. And they observed this phenomenon in about 8% of their patients. And proof that this was resistance is that increasing the dose didn't restore therapeutic response. In tachyphylaxis, that sometimes can restore therapeutic response. And they also observed this interesting phenomenon that a person developed bilateral resistance after a unilateral episode of uveitis, which gets back to the idea of clearance or reduced effective half-life of the drug based on some immune response that the patient might have, which, by the way, is one of the reasons why ranibizumab does not have an FC component. It was anticipated in developing ranibizumab that you could reduce the likelihood of an immune response to the drug by eliminating the FC component, which is one of the components, of course, of Avastin as well as aflibercept. It took time to develop this resistance. The average was around 100 weeks. That's another feature that's not consistent with tachyphylaxis. Tachyphylaxis develops rather quickly in classic pharmacology after the administration of the drug. And this conclusion that tachyphylaxis can occur after long-term intravitreal use of bevacizumab, in my experience, that's where we see resistance. We see it not immediately or shortly after the initiation of therapy. That would potentially be tachyphylaxis. Instead, we typically see it, I typically have seen it, after the patient's received a number of injections. Okay, so what can we do to the poorly responsive patient? Well, switching, I'm sure you've all heard of it. I'm going to talk a fair amount about it. But switching to a different anti-VEGF agent is something that you can do, and it seems to work, in a sense. But another thing you can do is increase the dose of the drug, or you could decrease the time interval between the injections. Those are pharmacokinetic responses to resistance. You could do combination therapy. For example, you can combine it with steroid, or you can combine with anti-VEGF with PDT. And then, of course, something we all should do when we are encountering resistance is to be sure that we have the right diagnosis. So this is a recently published meta-analysis of a number of switching studies, and this included 4 prospective and 4 retrospective studies. And if we look at the visual acuity results, which is what's shown here in the forest plot, you can see that the visual acuity results in the prospective studies intended to indicate that there would be a visual benefit to switching. But in the retrospective studies, there really was no visual benefit to switching because the difference between the mean values before and after switching is close to 0. And overall, there was a very marginally significant benefit. A p-value of 0.04, contrary to what we were taught in medical school, is really not a statistically important result, especially when we're talking about clinical trials that have so much variability in them. So I would say that the meta-analysis indicates that switching, at least in these studies, really didn't provide a very important visual benefit. But if we look at the anatomy after switching, there's a clear message. In the studies where it could be analyzed, there seemed to be a clear benefit favoring aflibercept. Now let me point out, all of these studies involve a switch from ranibizumab to aflibercept. And there seemed to be a clear anatomic benefit with thinning of the retina after the switch was made to aflibercept. So, the way I would summarize all this is by saying the meta-analysis indicates there's possibly a small visual benefit to switching. It's probably not clinically important. But there is a consistent reduction in central retinal thickness, which is statistically significant. But the clinical importance of it to me is unclear because it didn't result in better vision for most patients. Well, there are a number of things that can affect your outcome of the switch. And they're not, to me, intuitively obvious. One of them is the posology. So that's indicated by this study by Francesco Ricci. So these are patients with neovascular AMD who were treated with ranibizumab and with a PRN schedule. And then they were switched to aflibercept. And there were two different paradigms that were used. One group of patients received the 3 loading doses of aflibercept and then were treated every 8 weeks, period, every 8 weeks. The other group of patients received the 3 loading doses of aflibercept and then were given PRN aflibercept. So these were all switched patients, but they had different treatment paradigms of aflibercept. And after 1 year, the PRN group did not have an improvement in their vision, but the fixed every 8-week cohort did have an improvement in their vision. It was small, but it was clear. The central retinal thickness was reduced by a greater amount in the patients that were on the fixed treatment protocol of aflibercept. And interestingly enough, there was no difference in the amount of fluid resorption in the retina for the PRN or the fixed treatment protocol regimens. Of course, there was, as you would expect, a difference in the number of injections, with the people on the fixed regimen receiving more injections. So I would say that it's possible that the potential benefits of switching could be influenced by the treatment paradigm you use once you make the switch. Now, all the switching studies that have been published are limited because they lack a control group. And as a result of not having a control group, these results are subject to confounding. There are 2 sources of confounding. First is a phenomenon called regression to the mean, which means that if a variable is extreme on its first measurement, even if you do nothing, the very next measurement is likely to be associated with a value that's closer to the true mean. And if it's extreme on the second measurement, it most likely means that on the first measurement, it was closer to the true mean. Because of that phenomenon, all of these switching studies suffer what's called sampling bias, whereas you're actually selecting a subgroup of patients that doesn't represent your total patient population. But let me see if I can make that a little bit clearer with a hypothetical example. Here you have 2 patients, patient 1 and patient 2. Patient 1 has a lot of variability in the amount of thickness in the retina every time you give the injection, but the average thickness is around 251 microns. I did the math on that, I'm not guessing. Patient 2 is much more predictable in the amount of thickness at each injection. And as you would expect, the retina is thinner, but it's not a lot thinner. I don't think anyone would say we could reliably measure a difference of 10 microns, even within a single patient from visit to visit. But if we were going to switch patients, who would we switch? We would switch patient number 1, right? And when would we switch patient number 1? When they look like they're not responding. And the result of that is, because of this phenomenon of regression to the mean, no matter what we do, patient number 1 is likely to do better after we, quotes, switch the drug. So, regression to the mean means we are more likely to select patient number 1 for a switch, and that's what leads to sampling bias. And patient number 1 is more likely to show improvement even without a switch. That's regression to the mean. So this is the problem with all the switching studies that have been done that have any magnitude of patients in them. Now, I'm going to show you slides that come from a talk that was given by Dr. Daniel Martin, who's the chairman of ophthalmology at the Cole Institute, and Dr. Frederick Ferris, who's the director of the Division of Epidemiology and Clinical Applications at the National Eye Institute. And what they did was they had a switching paradigm. They said, we will switch patients if they have persistent foveal fluid, if they have vision of 20/40 or worse, if they've had less than 1 line gain from baseline, and we will consider switching them under 2 circumstances. First, we'll switch them at 3 months if they received all their previous loading doses, and the second cohort will switch at 6 months, provided they receive 5 out of their 6 monthly injections before the switch. And look what they found. If we look at the patient switched at 3 months, after the switch would have occurred, there's about a 3-letter gain and a decline in the OCT thickness. And if we look at the ones who would have been switched in 6 months, there's almost a 6-letter gain and a decline of about 40 microns in the OCT. Pretty impressive. And if you look at the amount of fluid in the fovea, by 2 years, half the patients had no more fluid among those who would have been switched at 3 months. And the same for those who would have been switched at 6 months. And here's an example of a person who would have been switched at 3 months. Their fluid goes away. And another example from a different patient. And all of these patients were derived from a PAT study. And they were all identified using the rules I just showed you. But none of them were actually switched. Not one of them. And that just shows you how you can be fooled if you don't have a control group. So among the people who could have been switched at 3 months, by doing nothing other than continuing their treatment, they got better, and their thickness got better, and their fluid got better. And if we look at the patients who could have been switched at 6 months, their vision improved without the switch actually happening, as did their retinal thickness, and as did the fluid at the foveal center. So, why do you see this? It's because of regression to the mean. It's very important. And you especially are going to be fooled by this phenomenon when you have an outcome variable that's varied from visit to visit, like a person's fluid and their visual acuity. Of course, there's also just the effect of time, because maybe it takes people longer to respond to the treatment, one patient versus another. And then there's something called the Hawthorne effect, which is that even if you don't change anything, once you've identified a problem, the problem seems to get better. And that's probably because you start doing more intense treatment and follow-up. So I'm not saying never to switch, and neither are they. But I will say that without a control group, it's hard to assess the value of switching. And almost certainly, the switching studies that have been published overestimate the impact of switching. Almost certainly. And Dr. Martin likes to say, you can always improve your results when you get rid of the controls. So is there anything approaching a control group for a switching study? The answer is yes, there is. It's a small study published by Dr. Irma Mantel. She has a very rigorous treatment paradigm known as Observe and Plan. And she selected a subgroup of these patients who required monthly ranibizumab injection at the end of 2 years. So these were clearly people that needed to be treated every month. And she subdivided them. Some she left on ranibizumab, and some she switched to aflibercept. Now, she really did switch them. This is not a fake switching study. And so this, as I said, is a small study of 10 eyes that were switched to aflibercept and 11 that remained on ranibizumab. They were very well balanced, and the outcomes I'll show you right now. So if we look at the patients in Group A, these were the people switched to aflibercept who had been on ranibizumab. These were the persons who were eligible for a switch, but they were remaining on ranibizumab. Look, if we didn't have the control group, we'd say, oh, when you switch, you increase the treatment interval in 60% of the patients. Of course, you did that for 50% of the patients in the control group. Or you could say, oh, when we switched, we made the macula drier in 40% of the patients. Well, you did that in 36% of the control group. Or, oh, we switched and we needed to give fewer injections. Well, that's the same as the number of injections in the control group. And here, the visual acuity results are actually worse in the people that switched than in the people who remained on ranibizumab. So I would advise to approach the published switching data with extreme skepticism in the absence of a control group. There are some very large studies, and I'm going to show you what I think is the largest one, that demonstrate the equivocal benefits of switching. So this is a study involving 384 eyes, basically out of Australia. And patients have been treated for an extended period of time before switching, 40 months. And 80% of these patients had active choroidal neovascularization at the time of the switch. And what you can see in the results is that, yes, after the switch, some patients gained 15 or more letters, but almost exactly the same percentage lost 15 or more letters. And essentially, half the patients didn't show any change at all in their vision. So the visual benefits of switching in this very large retrospective study are nil. And if we look at the number of injections, what you'll see is that the average number of injections before the switch was around 4, and after the switch it was reduced, but only by about 1 injection over a 12-month interval. It was a significant reduction, but I doubt that that would be a clinically important reduction. So, if we compare the patients before and after the switch, the first thing we see is that people who were treated for the longest time before the switch started out with a worse visual acuity. They had 61 letters versus 65 letters. But if you look at the change in vision, because you might be thinking, oh, they waited too long to switch, and that's why you didn't see them. Well, the people who were within 12 to 24 months showed the same change in vision as the ones who had been treated for 49 or more months before the switch. And essentially, none of them showed any change. And if you look at the treatment intervals, the intervals were increased by the same amount regardless of how long you've been receiving ranibizumab before the switch. So I think that this sort of study makes me think that switching doesn't help very much for most people. They actually had some patients that switched back from aflibercept to ranibizumab, but the number of patients involved was relatively small. And I think the main conclusions of this study is that the visual outcome from switching from aflibercept to ranibizumab was really not clinically important. There was a modest increase in the treatment interval and a somewhat greater proportion of the eyes that were rated as inactive after the switch. Well, tachyphylaxis, I told you I would mention what I think it is. I mean, it's defined as an acute, rapid decrease in the response to a drug after its administration. This is the kind of thing that happens when you administer a drug, for example, an antidepressant that depletes the synaptic terminals of norepinephrine. Immediately you get an effect, and if you keep giving the drug, well, the synaptic terminals are empty, so there's no more drug effect. So it usually occurs after a small series of doses, not after an extended period of time. I'm sure it occurs, but it's very uncommon, and most of what we're talking about is resistance in tachyphylaxis. Well, let me show you this patient to introduce the idea of switch back. So this woman, a 65-year-old woman with choroidal neovascularization and an initial vision of 20/25, she was initially treated with ranibizumab, did very well. But a year after her initial injection, she developed a recurrence that was unresponsive to 7 ranibizumab injections. And that's around the time that aflibercept became commercially available in the United States. Her vision was decreased now to 20/40. And so here she is, and I said, we should switch from ranibizumab to aflibercept, and let's see what happens. So we did. And her fluid went away, her vision improved to 20/30, and I thought, this is excellent. But then she developed recurrent fluid after 4 aflibercept injections. She happens to be the secretary of my dentist. She's a very smart person. And she wanted to go back to ranibizumab. I didn't want to argue with her because of a variety of reasons, so I did what she said. And so I gave her, at this point, ranibizumab, and she got better. And she kept responding to ranibizumab. So that's the idea of switch back. And there are 2 studies about switch back that I think are relevant. One is published by Sleem and co-workers. It's a retrospective series. And these are people who were switched from bevacizumab or ranibizumab to aflibercept, and then because they stopped responding to aflibercept, they were switched back. And this is a small series of patients. But they received a substantial number of aflibercept injections, about 7 after the switch. And here's what they found. Immediately after the switch, the central macular thickness improved from 317 to 285, but then it got worse while they were on aflibercept. And then when they switched back to ranibizumab, it got better. And the total volume of subretinal fluid did exactly the same thing. It got better initially with the aflibercept, then it got worse on the aflibercept, and then they switched, and it got better. And so the aflibercept switch initially looked to be beneficial, but eventually these patients were resistant to the aflibercept, and they did seem to respond to a change back to ranibizumab. And here you can see the data shown graphically. I'll just show you part of it. Here we're plotting central macular thickness as a function of when you are in the switching. So here you can see before the switch, they're 330, 320. After the switch, their thickness goes down, but then it goes up again when the aflibercept. They're switched to ranibizumab, and it goes down significantly. Here is the subretinal fluid, does the same thing. They go to the aflibercept, and there's a reduction. Then it goes up on aflibercept, and they go back to ranibizumab, and it goes down. This is the second study with switchback. It's also retrospective, many more eyes, 47. And these are patients who initially were treated with ranibizumab, switched to aflibercept, and then reverted to ranibizumab. And you can see a variety of different types of neovascularization included, but it was mostly occult. And there was a substantial number of injections given before the switch, after the switch, and a few after the switch back, which is a limitation of the study. Here, this is the result. The mean visual acuity initially goes down after the switch from ranibizumab to aflibercept, and then on the switch back, it goes up significantly. And the central foveal thickness initially goes down on the aflibercept. Remember, I told you that's the very consistent finding after the switch, is the thinning of the retina. But it goes down even more after they switch back to ranibizumab. Now, you know, this study has a lot of limitations, which the authors are well aware of. It's retrospective, it's a small sample size, with only short-term follow-up. But there is a sort of consistency to the switching study results. Usually, you don't see an improvement in the vision. Usually, you see anatomic improvement. When people stop responding to one drug, it's not crazy to switch them to another drug. It's sometimes you seem to get a clinical response, so it's worth doing. If they stop responding to the second drug, you ought to consider switching them back to the other drug, because sometimes that seems to work. Why is still unknown. When would you consider a switch? I would say they have to have at least 3 to 6 injections before you decide that they're resistant. And I would say that no improvement means less than a 100 micron decrease in their central macular thickness or persistence, particularly of subretinal fluid. Intraretinal cysts tend not to resolve with any therapy, aflibercept or ranibizumab or bevacizumab. So subretinal fluid, I think, is a good reason to make a change. Well, I've told you a lot about switching. Now let me tell you about changing the dose. There is a nice study. It's called the SAVE study. It's a small phase 1 to 2 multi-center study. And they looked at patients with recalcitrant neovascular AMD, despite monthly injections. And they increased the dose of ranibizumab from 0.5 to 2 milligrams. And there were 87 patients, and they had an average of 24 injections of 0.5 milligrams before the increased dose. And what you can see is that going to the higher dose actually produced a modest visual improvement. It produced a modest reduction in the retinal thickness. So therefore, it looks as if increasing the dose can be effective. What about changing the interval between doses? Well, this is a patient reported by Dr. Phil Rosenfeld, and they have an unusual paradigm, which I won't describe, but here's the patient. Initially, 2025, they get ranibizumab injection every 4 weeks, and you can see that the fluid, despite these repeated 4-week injections, is not going away, maybe even got a little bit worse. So eventually, when the vision drops to 20/60, they switch to bevacizumab, but they don't just switch the drug. they switched the injection interval to every 2 weeks, and you can see that the fluid goes away now with the 2-week injection. They needed to be injected every 2 weeks for the fluid to go away. Now, if they had injected the ranibizumab every 2 weeks, would that have worked? I don't know. But my bet is that changing the frequency of the injections was an important part of getting the fluid to resolve. What about combination therapy? Well, Dr. Shahal, when they reported this phenomenon of tachyphylaxis, noted that when they combined bevacizumab with photodynamic therapy, they actually had greater efficacy compared to bevacizumab alone. So, excuse me, with intravitreal steroids. This is the preservative-free intravitreal steroid that they were using. So, combining anti-VEGF with intravitreal steroids, maybe that could help in patients that are resistant. It seemed to in this series. Of course, another thing we can do, particularly with PCV, is consider combining anti-VEGF therapy with PDT. And I'm sure you know more about this now than I do because you just heard Dr. Coe's lecture. But the point I want to make here is that the combination therapy, the main benefit is it eliminates the polyps. It doesn't seem to improve the visual outcome, but it does seem to thin the retina more than monotherapy. So maybe that, for the right patient, would be the right change in your paradigm when they seem to be resistant. And the last thought that I want to leave you with is the idea of the incorrect diagnosis. If I showed you this patient, and this is unfortunately not an EDI-OCT, so you can't see that the cord is thickened, but it is, and you see this picture, you can't really know for sure that this is central serous retinopathy versus polychoroidal retinopathy. But if I tell you it's a 35-year-old Hispanic male, and that they get better with no treatment, and that the other eye has similar lesions, then you know, okay, it's actually CSR and not growing vessels. So whenever you see a resistant patient, it's probably not a bad idea to reinitiate all your diagnostic studies, fluorescein angiogram, maybe an ICG, just to be sure you do have the correct diagnosis. So in summary, the approach that I'd suggest for the patient with unresponsive choroidal vessels and AMD is to verify the correct diagnosis. My first response, if it is the correct diagnosis, would be to switch the medications. Despite all the limitations of the studies, there seems to be some value in it. Another option would be to increase the dose, which you can fairly easily do with ranibizumab. Or decrease the interval of injections. In fact, something that I think is very useful when you think a person is resistant is do the injection the way you normally would, but instead of seeing them back in 4 weeks, see them back in a week or 2 weeks. Because if they're responding to the drug, you will see a change in the subretinal fluid at the 1 or 2 week interval. And if they're truly resistant, you won't see any change at all. And if you do see the response with the absorption of fluid in 1 or 2 weeks, that's a good indication to change your injection interval from 4 weeks to 2 weeks. And I think it's especially safe to do that with ranibizumab because the systemic clearance is much faster than with aflibercept or bevacizumab. And then finally, combination therapy is an option, which today is sort of limited, but hopefully with the agents that I was describing to you in the previous lecture, combination therapy will become a useful option going forward. Thank you for your attention. If you have any questions, I'd be happy to answer them.
Thank you for all the summary. I tried to catch up with all of the article. So what is your definition of the non-responder tachyphylaxis?
I've never seen a patient with tachyphylaxis. I'm sure of it. Everyone that I've seen that stops responding has received multiple injections. So I wouldn't conclude that I had treatment failure unless I'd given at least 5 or 6 injections. And because I just showed you data from the CAT study, yes, which shows that if you didn't do anything different, but you just kept injecting them beyond 6 months, so that's a minimum of 5 injections, they responded. So I think we have patients that respond very quickly to the medicine, and we have patients that take a longer time to respond. but there are not that many patients that don't ever respond.
Okay, and then for the patient who is response at the beginning, the fluid go away and keep injection like every month, and then the fluid come back.
Yes.
So what do you call this?
That could be a person who's not responding. So if it's every month that and it's been working,
yes.
and now you come back at that following month, and now they have fluid, and you inject them, and they come back again, and the fluid's not gone.
Yes.
I would think about doing that test of injecting them again with the same drug, whatever it is, seeing them back in a week or 2 weeks with an OCT, just to see if the fluid went away at all. If it went away, then I would decrease the interval of injections. If it didn't go away at all, I'd think about switching them to a different drug. And usually the drug that I switch to, if I'm starting with ranibizumab, I'll switch to aflibercept typically. But it could work just as well as switch to bevacizumab as far as I know.
But if you use bevacizumab, are you going to switch to ranibizumab, or are you going to switch to
I'm going to switch to ranibizumab. And the reason is, it's really simple. It has to do with the pharmacokinetics of the drugs. I think that ranibizumab, I could be wrong, but the pharmacokinetics are pretty compelling to me. It's probably safer for older patients, especially someone who has a history of a stroke or cardiovascular disease. So, but I've certainly used aflibercept, and I've switched people to aflibercept, and I think nothing of it. But I almost never start with bevacizumab, because where I work, even if a person's poor, I can get the ranibizumab for them through a special program that Genentech has. So there's no economic reason for me to use bevacizumab. And bevacizumab has to be made by our hospital pharmacy, which means the patient will be in my clinic for an hour and a half longer than they need to be, waiting for the bevacizumab. So there's no value in using it. So I always use the ranibizumab as the first drug. But if you always wanted to use aflibercept or bevacizumab as the first drug, I think that would be fine.
And after you switch it, can you switch back? If it is not responsive.
Absolutely, and I've done it. And I can't say that it works. I've given you the argument as strongly as I can that if you don't have a control group, there's no really sure way to know that switch back works, or that switching works. But I have observed that when people stop responding and I switch, I've often seen them seem to respond anatomically. I have not seen improvement in vision, but I have seen the anatomic response, which I think is useful. And then when they've stopped responding to the switch medicine, I switch them back to the original medicine. And then I've seen them get better on that too. Just like that lady I showed you. I mean, she's not the only patient I have that's like that. She's just the first patient I had who was like that.
And then for the anatomical response, like sometimes the fluid gone, like there's no subretinal fluid, but they still have some like cystoid change in the retina. Do you count that as a non-responder?
Usually not, and I'll explain why. This has actually been studied very intensively by Dr. Schmidt-Erfurth in Vienna. And the thing that seems to respond the least to all the drugs is the intraretinal cystic change. So let me explain. If the patient starts out with the intraretinal cysts and the subretinal fluid, and I inject them, and the fluid goes away, but the cysts don't, I don't worry about that. On the other hand, if the person starts out with no intraretinal cysts, and then they develop fluid and the cyst, or just the cyst, I treat that. And I have seen that go away. So you see, how I manage it depends on what they started out with. Does that?
Yeah, it's kind of clear. It's like, no, sometimes we just see the cyst, and then we're just wondering that should we count that as an activity of the disease?
Well, you can, but the way I would suggest you approach it is that if everything else is getting better, but the cysts aren't getting better, don't worry about it.
And
Tôi xin hỏi, tôi có một bệnh nhân là mắc bệnh nhân mắc bên phải, bệnh nhân đấy là có sẹo do AMD rồi. Mắt thứ hai, bệnh nhân đã được trích ranibizumab 10 mũi do AMD. Sau đó bệnh nhân ngưng lại và 1 năm sau xuất huyết tái phát. Nhưng mà cái khó là bệnh nhân vừa bị tai biến mạch máu não nhẹ. Thành ra bây giờ không biết tôi nên điều trị như thế nào bệnh nhân này.
So let me summarize it for everyone who may not have understood what you said. So they only have one good eye. That eye has developed a significant hemorrhage, and they have had a stroke. That's the perfect patient to use ranibizumab in, because there's a reason to try to treat them, even though there's a risk associated with the treatment. And based on the pharmacokinetics of the drugs, ranibizumab, in my opinion, is probably the safer. If there's a difference, it's probably the safer of the 3 drugs. Something you could even consider doing is, if you have access to it. I have access to the 0.3 milligrams and not just the 0.5 milligrams. But something you could consider doing is injecting 0.3 milligrams instead of 0.5, or injecting half of the 0.5 milligram dose. And the other thing I do, and this sounds perhaps very compulsive, I warn every single patient, about the risk of stroke and heart attack with the intravitreal injections, because there is solid evidence from randomized clinical trials that there is an increased risk of death with the drugs in highly susceptible patients. Most of our patients are not highly susceptible, but a person with a recent stroke may be one of those patients.
And so, according to the patient, so what is the interval after the patient has the stroke that you feel comfortable with the injection?
So by the time they can make it to my office, it's been at least a month, right? Because people, if they get the TPA, they're in the hospital for a couple of days, and they're just not coming to me within a week of the stroke. So in a way, it's a very theoretical situation. But, again, you might think this is very compulsive, but in that patient, I first call their cardiologist to tell them what I'm going to do. It almost never matters, because they have no knowledge of any of the things that we're talking about. And so they always tell me, do whatever you want. But I still call them just so I can say that I discuss this with their doctor, and their doctor doesn't object to me giving the treatment. Of course, I discuss it with the patient. And now we're really talking about a person that has only one seeing eye. And those patients almost always want to receive the injection. And I feel okay doing that.
Sorry, another question. We have some patients that have the breakthrough vitreous hemorrhage and go into vitrectomy. In the post-vitrectomized eye, so sometimes we continue to have to inject. Do you consider the resist some kind of non-responsive in vitrectomized eye, and how do you manage them?
That's an interesting question, because you would think that after you do the vitrectomy, that the clearance of the drug would be much faster, and you'd have to inject more frequently. And that might be true. In the diabetic patients that were enrolled in Protocol I, this was actually studied. So these have a different disease, but here they are, diabetic macular edema patients that have had a vitrectomy. It turned out there was no increased frequency of injection needed after the vitrectomy. That doesn't mean that would be true in a person with age-related macular degeneration. The reason I say that is that diabetic macular edema is probably a much more purely VEGF-driven process than the edema associated with choroidal neovascularization. So it could very well be the case that in the AMD patient, after vitrectomy, they are going to need more frequent injections than every month. But we don't have to be theoretical about it. What I would do is I'd inject the patient, and I'd see them back in a month. And if they hadn't responded, I would do another injection, but I'd see them back in 2 weeks and see if there was any evidence of a clinical response. And if that was the case, that would make me think that maybe I needed to increase the frequency of injections. So I'd be very careful about it. Yes?
Thank you for the comprehensive data and also the conclusion. I wonder if the subtype of the AMD, like the PCB, you can change the decision choosing the drug or switching the drug.
It doesn't, but I'm very careful about that. I actually would rather have Dr. Ko answer that question because I'm concerned that the PCB patients that you see are not the same as the PCB patients that I see. But as it turns out, I have a patient in my mind right now who was actually sent to me as having diabetic macular edema, who was misdiagnosed. What she actually had was PCV and clinically unimportant diabetes, which is a very low hemoglobin A1C. And that person stopped responding. I think I started her on ranibizumab. She stopped responding to that. I switched her to aflibercept, and she responded. So, in my little PCV experience, I switched. I tend not to go to PDT. And the reason is that unless you're set up to do PDT all the time, it's an event. It'll ruin your patient throughput. And there's a certain fraction of patients, not so much with the half dose, but in the old days with the full dose, that actually get significant choroidal non-perfusion in the macula. And I do have one patient who actually had very significant central visual loss. So that has really made me use PDT as when I'm not getting anywhere with the anti-VEGF drugs, even with PCV. But, as I mentioned earlier this morning, I have used it, and it's been very helpful to me when I've used it. So I don't want you to think I'm biased against it. It's just that it's not the first thing I go to when I think I have a resistant patient.
Another question about the protocol T. According to the 1-year result and 2-year result, can you, the 2-year result is more likely to be about the same, right, as 2 years. So what do you think is the reason behind it? Is that about what you say? And people talking about the area under the curve. What do you think about it?
Okay.
Sorry.
Please.
Another thing is, we always thinking about the statistical significance and clinically significant. And most of the time it's about, it's very small.
Hold on. I want to show you something. Since you made the mistake of asking that question, I'm going to show you something that I think will work.
Lấy nhà em làm list nha, checklist đó nha. Checklist gì? Hả? Checklist gì? Tiêu chuẩn cứ nó xong mình đặt trước mặt mình, xong rồi mình làm xem.
Just a second. Okay, I think this one. Oh. Yes, this is the slide. Okay. So the very first thing I want to point out to you is that you treat with 0.5 milligram ranibizumab. That's a very important fact. You see, protocol T used 0.3 milligram ranibizumab. Now, if you go back and look at the studies that have been done, 0.3 milligram monthly, 0.5 milligram monthly, and 0.5 milligram PRN, you can actually calculate the average dose that the patients who are getting 0.5 milligram PRN received on a monthly basis. That dose was actually 0.35 milligrams. So the only, and protocol T, as you know, is a type of PRN treatment protocol. So there is no treatment protocol studying 0.3 milligrams PRN except for protocol T. And based on such studies as do exist, you can expect that 0.3 milligram PRN is slightly underdosing patients. So you don't need to worry about it. I mean, protocol T for you is irrelevant. You're treating with 0.5 milligrams. How many of your patients have ever seen anti-VEGF therapy for a year? I mean, you know. So that's why you have to be careful. But this question about the the drugs at 1 year and 2 years. This is the data from protocol T at 2 years. So what you can see here is that aflibercept and ranibizumab have the same change in baseline, but bevacizumab is worse, right? 5 letters worse. Highly statistically significant, 0.02. Okay, look. That's not the data from the trial, really. This is a mathematical analysis of the data of the trial. Think of it this way. There's a range of responses to aflibercept. There's a range of responses to ranibizumab. There's a range of responses to bevacizumab. Comparing the means doesn't tell you how much overlap there is. In fact, let me say it a different way. If the mean is 18 letters of improvement, that means half the patients got less than 18 letters of improvement. If the mean is 16 or 13 letters of improvement, that means half the patients got more than 13 letters of improvement. So how do you figure out to the degree to which the distributions overlap? The way you do that is by looking at the tails. So that would be the numbers of 15 letters of improvement and the numbers of 15 letters of loss. And there, you see, in fact, no difference between any of the drugs at 2 years. So, the fraction of patients that get 10 letters of improvement, it's the same for all the drugs. The fraction that get 15 letters of improvement, it's the same for all the drugs. The fraction that lose 10 letters or lose 15 letters, it's the same for all drugs. So when you are a patient instead of a doctor, and you're trying to decide which treatment to get, you don't want to know what the average result was. You want to know what's the likelihood of getting a clinically important result. A clinically important result is 15 letters of gain or 15 letters of loss. Well, the drugs are the same. Okay. Now, the question of the 1 year versus the 2 year, I'd just be making up the answer. But let me show you something. I will just tell you this. If we look at the View 1 and the View 2 trial, so these are prospective, randomized, multi-center controlled clinical trials, which are supposed to be replicas of each other. The View 1 trial showed that the aflibercept every 4 weeks was better than the ranibizumab, and the View 2 trial showed exactly the opposite. So what does that tell you? It tells you that you can't replicate things in clinical medicine. Replication means if I do the exact same experiment twice, I'll get exactly the same result. Right? In clinical trials, that's impossible. Because you can have the same protocol, you can have the same drug, but you don't have the same patients. Well, here is a little bit different because you do have the same patients. But I guess the way to think about this is, which is the aberrant result? The year 1 result or the year 2 result? Because the year 2 result is consistent with all the published literature. The year 1 result isn't consistent with any of the published literature, including the previous Vivid and Vista trials or the Wright and Rice trials. So, and it's a single trial. It's a single randomized trial, protocol 2. You could not get a drug through the regulatory authorities with the protocol 2 trial. It wouldn't work. You need 2 trials. So I don't worry about the year 1 data. I worry more about this. I say, if my patient in front of me, is it like the patients enrolled in protocol T? Yes or no? If they're not like the protocol T patients, I have low confidence that I will reproduce the results in protocol T. Second question, is the drug I'm using the same as in protocol T? Yes or no? The answer is yes if I use 0.3 milligrams, no if I use 0.5 milligrams. So that's why in Europe and in Asia, where you use 0.5 milligrams ranibizumab, I think protocol T is interesting. I don't know how really to apply it rigorously to the results of your clinical practice.
And how about the error learning curve? So if repeatedly happen, whatever the...
Well, so let me get at that. So the issue there is, okay, for how long. So let's suppose that the protocol T results are reproducible. Okay, not replicable, but reproducible. Well, then the question is, okay, when here's aflibercept patients doing better with 20/50 or worse, and ranibizumab and bevacizumab not doing as well, but at some point they come together. For how long was there a difference in the visual outcome? That's what the area under the curve measurement really addresses. And essentially, it's for about a year. That would be the answer based on that. Does that make sense? But I think this obsession with focusing on the mean values is a complete error in the way we were educated. The true clinical trial data are not up here. This is a mathematical analysis that's actually based on false assumptions. The first assumption it's based on is the idea of replicability, which is a false assumption in clinical trials. Something closer to the true data is looking at the tails of the distribution, but the real thing to see is actually look at the curves. Because once you see how much overlap there is in the clinical results, you'll know intuitively as a doctor, there's very little difference between the points. You don't need to be a statistician to understand that. Okay.
Talking about the suboptimal dose, and sometimes we inject, like doing an intravenous injection, and then there's some drug reflux
Yes.
and we saw that they need many times, even we do a conjunctival displacement. So what do you think about that? And should we inject more medication?
No. So the first thing, I guess everyone does this more or less the same way, but I put the needle in all the way, and after I inject, I leave the needle there for 10 seconds. I count to 10, 1, 1,000, 2, 1,000, to give it time, because the drug is, you can watch it settle down below, so that when the reflux comes, it's actually much less of the drug than you would think. And the trials, where the injections weren't done with this sort of meticulous attitude, show the visual benefits of just injecting 0.5 or 2 milligrams depending on the drug. So I wouldn't, they had reflux too, in other words, so that's why we wouldn't.
And so you leave it for 10 seconds. Do you use it just to top anesthesia and use it on top?
That's a great, okay, so that's, I'll tell you what I do, but there's a reason for it. I actually use the lidocaine jelly, and the reason I do that is topical anesthesia, if you're using the betadine vigorously, is not enough. You'll find that out very quickly, and there's no point in torturing your patients. It's bad enough that they have to get an injection. Now, once you decide that topical anesthesia with the drops is not enough, then you have a choice. You can use the lidocaine gel, or you can use subconjunctival injection. Well, subconjunctival injection is probably actually a little better than the lidocaine gel. But if you're doing something over and over and over again, guarantee eventually you're going to have a complication from the subconjunctival injection. It might take 5,000 injections, it might take 20,000 injections, but eventually you will. So the way I think about surgery is I only do what I have to do. And the lidocaine gel has zero possibility of an inadvertent perforation. Zero possibility. And it works perfectly well. And because I do 3 betadine washes before I do the injection. The reason I do that is because the patients are older. I'm not confident that they wash their hands. I'm not confident that they get the antibiotic drops in their eye. And so I try to be very obsessive that the surgical field really is as clean as I can make it before I put the needle.
How long do you put it for you?
So it doesn't work as fast as you would think. And so what I do, once I've consented the patient, I put the gel in right away, and then I start doing the other things that I have to do to take care of the person, like the charting and that kind of thing, and the coding. And And by the time I'm done with that, at least a minute or two has passed. And at that point, the gel is removed.
Thank you very much, Marco. We'll have to move on. Our next speaker is Dr. Quinn.